My name is Ali Abadi, and I'm one of the radiology residents at the University of Washington. Today I will be presenting on atypical insufficiency fracture. I wanted to thank Dr. Majid Chalian, my mentor and one of our faculty at the University of Washington. This is a 52-year-old male with a history of castrate-resistant prostate cancer and multiple osseous mets involving the spine and pelvis. He presented with acute on chronic left hip pain, which was worse with weight bearing. He had been on denosumab therapy for 6.5 years. On physical exam, he had left hip pain at rest and with ambulation. There was no significant change in pain with palpation. His range of motion was symmetric in comparison to the contralateral side. On imaging, AP radiograph of the left hip demonstrated focal cortical thickening in the lateral cortex of the proximal femur, demonstrated by the yellow arrow. This was concerning for an underlying atypical insufficiency fracture. On CT, sagittal and coronal reformats demonstrate focal cortical thickening of the left femoral lateral cortex concordant with the patient's radiograph. The yellow arrow denotes a subtle linear lucency consistent with the transverse fracture line of the atypical insufficiency fracture. As expected, whole body bone scintigraphy using technetium-99m MDP demonstrates focal uptake in the left lateral proximal femoral cortex, shown by the yellow arrows. On MRI, axial T1 weighted images demonstrate focal lateral femoral cortical thickening. Adjacent to this region, the marrow demonstrates low to intermediate signal with smooth borders consistent with preservation of marrow fat, shown by the blue arrow. On axial PD FATSAT and coronal stir sequences, there is increased signal intensity in the marrow, shown by the blue arrows, consistent with edema. There is no adjacent soft tissue component. Given the patient's prolonged history of denosumab therapy, the transverse orientation of the fracture line, and the location of the fracture in the lateral subtrochanteric region, atypical insufficiency fracture is the most likely diagnosis. The differential diagnosis includes osseous mets, fatigue fracture, or insufficiency fracture. Preservation of marrow fat and lack of soft tissue involvement on MRI make osseous metastatic disease less likely. The lack of recent change in physical activity make fatigue fractures less likely. Lastly, insufficiency fractures commonly occur along the medial aspect of the femur, not the lateral. The takeaway points from this presentation are as follows. Bisphosphonates and RANKL inhibitors inhibit osteoclast activity to increase bone density. Inhibition of osteoclast prevents bone remodeling. Over time, accumulation of microdamage to the bone without bone remodeling places the bone at increased risk for atypical insufficiency fracture. Atypical insufficiency fractures are unique in their location, usually occurring distal to the lesser trochanter and proximal to the supracondylar flare. Patients tend to have prolonged symptoms preceding the fracture. On imaging, radiographs and CT show the periosteal reaction of the lateral femoral cortex and possibly a transverse or oblique fracture line. The same area shows increased uptake on technetium-99m MDP bone scan. On MRI, there is low marrow signal with smooth borders on T1, high marrow signal surrounding the fracture line on T2, and intense enhancement with gadolinium administration. Remember to think about atypical insufficiency fracture in patients on bisphosphonate therapy for greater than 3 to 5 years. Lastly, these patients are at increased risk for having an atypical insufficiency fracture on the contralateral side, even if asymptomatic. Therefore, consider acquiring contralateral radiographs. Thank you for watching this presentation, and we hope that you found this to be educational.